Good afternoon. Thank you SSI and Sarthak sir for giving me this opportunity to speak here. My topic for today is Achilles Repair and what are the recent advances. So what is the need for any advancements in Achilles surgery that we have been doing all open surgeries? So the focus is basically on minimizing the surgical complications, improving initial repair. Repair is less post-operative pain, faster recovery, shorter hospital stay and low risk of wound complications. So some of the recent advances are using a mini open technique for repair, ultrasound guided percutaneous repair, endoscopic repair, knotless anchor fixation, biological augmentation and non-operative management. So mini open technique blends traditional open surgery with percutaneous techniques. This requires only a small incisions which enables the surgeon to directly visualize the tendon position while significantly lowering the risk of wound infections. For example, the percutaneous Achilles repair surgery system developed by Arthrex. The ultrasound guided percutaneous repair uses ultrasound imaging which guides the precise placement of sutures and anchors for tendon repair. During the repair process, the surgeon makes a small incision and uses an ultrasound probe to visualize the tendon, which offers the advantages of accurate placement of sutures and clear depiction of the sural nerve, which can be iatrogenically injured during this procedure. And of course, the drawbacks are USG is an objective procedure which is user dependent, and some cases have lesser tensile strength of the repairs as compared to the open methods. Endoscopic repair also involves an insertion of an arthroscopic probe through medially placed tab incision to visualize the tendon and perform repairs. Excellent results in terms of early return to physical activities, minimal wound complications and iatrogenic nerve injuries have been reported with endoscopic repair of Achilles tendon. Knotless anchor fixation, many modern procedures utilize knotless biocomposite swivel lock anchors rather than the rigid heavy suture knots. This distributes the tension across the footprint of the tendon, thus providing immediate rigid stability, which allows the patients to bear weight and begin motion much earlier. For example, the speed bridge system by Arthrex. Biological augmentation includes regenerative therapies and biological scaffolds. Regenerative therapies include growth factor mediated therapies that are applied to the repair site to promote robust collagen organization, enhance tendon to bone healing and reduce elongation. Example include fibrin glue, platelet-rich fibrin matrix, autologous platelet-rich fibrin and bone marrow aspirate concentrate. Scaffolds and grafts can be used for chronic ruptures or cases involving poor tissue quality or when the gap between the fragments is too more, so that synthetic or biological scaffolds can bridge the gap and reinforce the repair site, hence reducing the reliance on older and highly morbid tendon flap techniques. So non-operative management should not be misunderstood as an absence of treatment. The current trends are functional bracing, early range of motion and early weight bearing. So instead of prolonged immobilization in rigid casts, patients are routinely placed into functional bracing with controlled range of motion within days of surgery. So functional bracing positively influences the maturation of collagen fibers within the tendon and prevents muscle atrophy. Early range of motion leads to improved healing through release of growth factors, decreased re-rupture rates and shortened rehabilitation time. Animal studies have also shown that 3 times increase in the strength of Achilles tendon in dynamic rehabilitation. Early weight bearing when compared to non-weight bearing, mechanical loading improves tendon healing. Randomized studies have showed that weight bearing groups had quicker return to normal working, better quality of life and no detrimental effects. So non-operative treatment protocol is same protocol we follow for post-operative surgery patients. First 2 weeks patient is put in equinus brace non-weight bearing. The next 2nd to 4th week partial weight bearing is allowed with active plantar flexion and dorsiflexion up to neutral. From 4th to 6th week full weight bearing allowed with equinus brace, and 6 to 8 weeks dorsiflexion is allowed above neutral and strength training is done. Post 8 weeks of surgery, no braces, patient is allowed to bear weight without any brace. So there are some studies which say conservative modality is at par with surgery. And this is the comparative analysis between conservative treatment, open treatment, and mini-open treatment using endoscope or arthroscope, jig, and ultrasound guided. So my take-home message is the primary goal of surgery is to repair the torn tendon and restore its function. The surgical approach depends on the surgeon's preference and patient profile and the severity of the injury. Surgery should be done for young active patients, and surgery generally gives more reliable calf muscle strength and in delayed presenting and chronic cases. Non-operative treatment can work well in rigid patients. The right patients. Functional rehabilitation is important to reduce re-ruptures and help with rehabilitation. Conservative management can work well with fluid and lesser active patients, patients presenting acute within 20 to 48 hours of injury, and patients having comorbidities like diabetes, coronary artery disease, peripheral vascular disease, and in smokers. Thank you.